All right, let's dive right in. Today, we are tackling a clinical puzzle you are going to see all the time: superficial fungal infections. Seriously, if you're a trainee in the clinic or on the wards, getting good at spotting and treating these is a skill you will use constantly. So let's get into it.
So picture this. A patient walks in with a rash. It's red, it's scaly, and it is super itchy. Now, your mind might immediately jump to things like eczema or contact dermatitis, but what if there's a sneaky little culprit hiding in plain sight?
Okay, take a look at this. This looks like a pretty classic case of severe hand dermatitis, right? You can see that redness, the erythema, and all that peeling, scaly skin, which we call desquamation. And you might think it's just an irritant, but this could absolutely be a fungus. And this is exactly where our investigation into dermatophytes really begins.
So, here's how we're going to crack this case. We're going to follow a really clear roadmap. First, we'll meet the culprits themselves. Then, we'll check out the crime scene, what these infections actually look like. After that, we'll open up our diagnostic toolkit, lay out a solid management plan, and finally, and this is key, we'll go over how to avoid some really common clinical traps.
First things first. Who are these infectious agents? Let's get a proper introduction to the dermatophytes. This image shows us exactly where these fungi set up shop. This is their turf. As you can see, dermaphytes are totally superficial. They live in the stratum corneum, that very top dead layer of our skin. And this is a huge point. They don't invade deeper tissues, which makes a big difference for both how we diagnose and how we treat them. Let's get the official lingo down. So dermaphytes are a specific group of fungi that cause these superficial infections. The really formal name for the infection is dermatophytosis, but honestly, in the clinic, you're almost always going to hear it called tinea. Now, these fungi fall into three main groups, or genera: Trichophyton, Microsporum, and Epidermophyton. It's good to know all three, but for your day-to-day practice, the one you really need to remember is Trichophyton. In fact, a single species, Trichophyton rubrum, is the usual suspect behind the vast majority of athlete's foot, jock itch, and ringworm you're ever going to see.
Okay, so we know who the bad guys are. Now let's move on to the crime scene. How do we spot these infections when they walk through the clinic door?
This table right here, this is your high-yield cheat sheet. The naming is actually super simple. It's tinea plus the Latin word for the body part it's on. So tinea pedis is on the feet. That's athlete's foot, and you'll often see it in a classic moccasin pattern. Tinea cruris is jock itch in the groin. Tinea corporis is that classic ringworm on the body. Tinea cachetis is on the scalp, and tinea manuum is on the hand. Just remember, in dermatology, location is everything. Okay, so you've got a hunch based on how it looks and where it is. But how do you prove it? Well, it's time to open up our diagnostic toolkit. And the great news is the workup is beautifully simple. It all starts with your eyes, a good visual inspection. If you're suspicious of a fungus, you move on to a skin scraping. Then you take that little sample and pop it under the microscope. And this right here, this is the gold standard. It's called a KOH prep. You just scrape the active red border of the rash, put the scales on a slide with a drop of potassium hydroxide, and look for those telltale fungal strands, the hyphae. This simple test confirms your diagnosis right then and there. Boom! Diagnosis confirmed. Now we gotta fix it. What's the game plan? Let's talk about effective treatment strategies. So, you'll face one key decision: topical cream or oral pills. The rule of thumb is pretty easy. For a small infection on skin without hair, a topical cream like terbinafine or miconazole is perfect. But, and this is a big but, if the infection is on hair-bearing skin, like the scalp where creams can't get down into the follicle, or if it's a huge area, or it keeps coming back, you have to go with an oral agent like terbinafine. All right, let's wrap this up with my favorite part, the clinical pearls. These are the common traps that you can learn to sidestep starting right now. First up, this is a huge one. It's so common it even has a name: the combination cream trap. You've probably seen these creams with multiple ingredients prescribed all the time. And here is why this is so important. Never use a cream that mixes an antifungal with a steroid. Why? Well, the steroid will knock down the inflammation, which makes the rash look better for a little while, but it's also suppressing the local immune response. That allows the fungus to just have a party and flourish, leading to treatment failure. We even call this tinea incognito. Just use a pure antifungal, period. Okay, our second pitfall is a classic diagnostic miss. A patient comes in with a rash on their hand, you're thinking fungus, but you forget one absolutely crucial step. This is a famous clinical pearl called 2 feet, 1 hand syndrome. It's this weirdly common pattern where a fungal infection on one hand is directly linked to athlete's foot on both feet, probably because the person is always scratching their feet. The takeaway here is so simple but so powerful. If you even think about tinea on a hand, you have to ask the patient to take off their socks and shoes so you can check their feet. Always.
And there you have it. That's our deep dive into dermatophytes, a superficial enemy that we can now confidently unmask and treat. We've seen that they live right on the surface, in that top layer of skin. But it does leave us with one last question to think about. What happens when an infection isn't so superficial? What happens when it decides to go deeper? Well, that's a whole other story for another time. Thanks for joining me.